Hi, everyone. My name is Dr. Curtis Lehman. I'm an associate professor in the Department of Psychology at Azusa Pacific University. And I am, as the title indicates, I'm going to talk with you about depression and rehabilitation. And I should share a little bit about my background. So I'm a clinical psychologist, and my doctorate is my PhD is in clinical psychology. And in going through grad school, one of my settings was a practicum at Casa Colina, which is a rehabilitation hospital actually out in Pomona that where I worked at a setting where it was called the Transitional Living Center at Casa Colina, where we were working with people with brain injuries. And so it was a sort of a residential rehabilitation facility. And we focused on people who had lingering symptoms after the hospital stay who needed additional care. And so I'm going to speak a little bit from my experience there, but I've also done a bit of a lit review on the topic to kind of bolster that. And yeah, I'm looking forward to this. So, okay, so let me jump into it. Depression and rehabilitation. What's the big picture? Well, it's important to recognize that depression could come into the picture for rehabilitation in a few different pathways. So, depression could be a risk factor for disease or injury. In fact, we know that to be the case for a number of conditions. So, cardiovascular disease, strokes, and a few other conditions have been related to where depression has been identified as a risk factor, as a contributing factor for the disease or injury. Now, you have to step back and think, okay, why might that be? Well, it is possible that depression, we know that depression is associated with a variety of behaviors. It's a behavioral disorder. And so as a result, the behaviors that the person engages in could be related to increased risk. So what that could look like is, dietary factors, because depression is associated with increased uh, appetite for some, and weight gain. And what it can look like is perhaps less, uh, you know, i- increased intake of calories or of unhealthy foods. So it can involve dietary factors that could be related to increased risk. It could also be associated with impulsive factors, such as being involved in a car accident. It could also be involved in a suicide attempt. We know that depression can contribute to a person thinking about suicide, and so that could be a factor that might be a reason for them actually, acquiring a traumatic brain injury or a gunshot wound or an overdose or yeah, a variety of methods can be associated with a disease or an injury in particular. Okay, so that's one part of it. But we also know that depression, although it's a behavioral disorder, it's also a biological disorder. It's associated with changes in our physical systems. And so depression could be associated with physiological risk factors. So one example we know is the cortisol. It's a stress hormone that is released in times of increased stress and in times of danger. And depression is associated with changes in cortisol levels in the body. And what could happen is that we know cortisol can be toxic over the long term to our physiology. So it increases, inflammation, and it tends to uh, be essentially, yeah, toxic or poisonous to the body if the body is exposed to it chronically. So it could be that depression leads to a release of cortisol, and cortisol in turn can increase risk of heart attack, of stroke, and other things like that. So it could be the physiological risk factors, or of course both. So that's where depression could cause the disease or injury, but it could also be the consequence of a disease or injury, right? Because a disease or injury could potentially increase risk of depression for a couple reasons. So kind of in the same way, we know that the disease could have physical impacts on the body or the brain in particular. And the biological aspects of the disease or the injury could, so for instance, traumatic brain injury, the damage to the brain could affect the systems that are involved in mood and motor movements and things like that. And so that could increase risk of depression, and it could be predominantly the physical and anatomical factors, or it could be the psychosocial aspects, right? That disease and injury can be life-changing. It could involve just rapid and um, complete transitions from work or education, or from social interactions. It could involve, impairments in ability to communicate, or sort of the change in one's view of the future. And all of those could have real uh, the considerable impacts on one's psychological functioning and one's social functioning. And so it could be, again, and I should clarify that I don't mean that it could be one or the other. It could certainly be both of those at the same time. They could be happening in coordination, where the physical and the psychosocial aspects of it could be coming together and really leading to a complete upheaval of their physical and psychological lives. Okay, now, so it's basically bidirectional, right? So depression could cause it, or it could be the disease can cause the depression. Now, the other couple ways that depression could be involved in rehabilitation is that depression could complicate prognosis. And what I mean is that sort of absent of treatment, I'll get to treatment in a second, but absent of treatment, the depression could have negative implications for the natural course of the disease. So it could increase mortality. It could increase morbidity, comorbidity of new uh, uh, biological problems or psychological problems or behavioral problems that could come about. It could, it could lead that person to withdraw from social supports, and or have social supports sort of pull away from them, and all that could again complicate their outcome. Now, it could also, and of course, again, these could go together, it could moderate the effects of rehabilitation or treatment, the interventions that you use, that depression could affect how effective they are. And what that could look like is we know that depression can affect motivation. So it could decrease a person's motivation to engage in interventions, because sometimes they're hard, right? That the things that we can ask our clients or patients to do are challenging and difficult and sometimes uncomfortable, and so that depression could lead to a lack of perseverance, and so the person might um, disengage from the activity more readily because of their depression. Kind of related to that, depression also causes fatigue. And so the person could become more fatigued as a result of, let's say, an activity that they're engaged in, and so they might again quit it more earlier than they would have otherwise. It could also affect their sort of cognitive appraisal of the situation. It could affect their belief that the interventions will work. So depression could cause them to become more pessimistic about, is this actually gonna make my life better? Because oftentimes depression affects our views of the future. It could affect the views of the clinic itself. They might have more negative views of the clinic or the rehabilitation center, hospital. It could affect. So again, it can moderate those effects, and usually the risk is that it could make rehabilitation less effective. Okay, so again, as we go about this, kind of think about that as in the background of all these studies that I'm going to show you. Okay, so all right, now next I want to talk about populations affected. So patient populations that we should be thinking about with depression, and this is by no means going to be a comprehensive list. So forgive me for that. I'm not necessarily an expert on that, but I chose a few conditions based on prevalence and based on just sort of the possibility that they might be more poignant in these situations. So first off, stroke and heart attack. Okay, so depression impacts 1 in 3 stroke survivors. And there's some indication that it can happen somewhere between 1 to 6 months following the stroke. So it's not necessarily immediately evident, but and in some patients it could be delayed for up to 6 months. But depression is very common, and so when you're working with stroke rehabilitation patients, you should keep that in mind. And in one study, in fact, we're going to talk a little bit about it later. There was some indication that apathy was related to functional independence during hospitalization, but depression was only marginally related. Well, that's kind of a good thing, right? That they found that depression wasn't really um, highly related to functional independence. Um, Again, typically, if it's related, it's going to be related in a negative way. So that's considered a good finding. And then in another study, and this was a longitudinal study, this was more negative. They found that decreasing self-efficacy over time was associated with increasing depression. So oftentimes the stroke has an impact on what's called self-efficacy. And let me explain this real quickly. Self-efficacy is different from self-esteem. Self-esteem is sort of a global appraisal of yourself as good or bad. So it's kind of a polarity between positive and negative. How do you look at yourself? That's self-esteem. But self-efficacy is the belief that you are able to accomplish certain things. So you can have self-efficacy in regards to statistics. You can have self-efficacy in regards to um, uh, writing papers, or you can have self-efficacy about rehabilitation efforts. And so what they have found is that self-efficacy is related to depression. And so if the person is decreasing in their view of themselves in regards to self-efficacy, that is going to increase their risk of depression. Okay, now for heart attack, we know again that depression is common among patients with ischemic heart disease and post-myocardial infarction. And post-MI depression is related to decreased adherence to cardiac rehabilitation and increased mortality risk. So if a person develops depression, it means that they're less likely to adhere to their rehabilitation. That's that moderating effect, and it can actually increase their risk of dying um, within a. I believe this is. Well, I forget what the time frame is, but after discharge, they can have an increased risk of death. Uh, Another study was it was a 25-year follow-up study and found that depression was linked to increased mortality following myocardial infarction. And in this study, mild depression, but surprisingly not low, moderate, or severe depression, what's not the part here that's surprising is the moderate or severe depression uh, was related to increased mortality at 25-year follow-up. So what I take away from this is not that moderate and severe depression is a risk factor for increased mortality. I don't think they had a large enough sample size to say that conclusively. But what I take away from this is that mild depression is not to be ignored in terms of risk of mortality. So it's not just patients with severe or even moderate conditions that we should be looking at. We should be screening for mild depression and treating it because it does have a risk for their survival. Finally, cardiac rehabilitation, and this is more of a positive finding, it was associated with significantly reduced mortality among depressed patients, but not in non-depressed patients. So I guess that second part is not the best finding because, of course, we want all people to be helped by rehabilitation, but at least we can see that cardiac rehabilitation is effective among depressed patients in reducing mortality. Okay, so again, these are common conditions, and so certainly we want to be mindful of them. But I want to talk also about spinal cord injury and traumatic brain injury. So for those who have a traumatic spinal cord injury, there was one study that found that 33.4% had a psychiatric disorder. Now, psychiatric disorders are broad, right? So there's even dementias or um, psychosis or anxiety. So I'm certainly not going to suggest that this is the rates of depression, but depression is the most common mental disorder in the DSM-5, and so I would venture to guess that a reasonably high percentage of these might actually have depression. Now, there's another caveat for this one because um, some of those who had a traumatic spinal cord injury may seem to have had concurrent traumas, such as a TBI, and so that might be increasing their risk further. But the point being that in the spinal cord injury population, we should be mindful of depression. And one study found that depression was more common among those under 35, among the males, and among those with low income. And again, this is a good example of thinking about why might an injury increase risk of depression. Because spinal cord injury would certainly not constitute a clear-cut case where the biology of it would necessarily be related to the etiology of the depression in this population, right? Because the spinal cord injury, we haven't kind of recognized it as an important pathway for depression. Or so the question would be, why might spinal cord injury contribute to depression? Well, of course, a big factor in it could certainly be the paraplegia or quadriplegia or the paralysis that is associated with spinal cord injury, right? So there's some real functional impairments that the person will experience as a result of their injury, and as a result, they may have they may have difficulty transitioning. So if this was, let's say, spinal cord injury as a result of a car accident, well, that could put the person at risk. If it was a car accident, they may have been employed, they may have been, you know, previously very physically active, exercising, and the spinal cord injury could have just a transformative effect on their life in what they might experience as in a negative manner. And so um, that psychosocial implication could actually have uh, some uh, could contribute to the risk of depression. Now, there's another possibility, which is that, and I find this kind of interesting, but treat it as a little bit speculative at this point. But we know that the rates of anxiety are related to the placement of spinal cord injury. So that a person who has a spinal cord injury that's lower has increased anxiety as opposed to someone who has a spinal cord injury that's higher. And that might seem even counterintuitive until you think about the fact that our bodies are an important source of feedback about our feelings. So it's interesting that the people with the highest spinal cord injury would have the least amount of anxiety, because in that group, they would have the least feedback from their body. If you think about anxiety, you realize that anxiety, we often feel it in our body. We feel the tingling, the butterflies, the knots in our stomach. It's a very physical disorder, or sorry, physical experience, right? Anxiety. And so spinal cord injury can wipe out some of that feedback. And as a result, a person doesn't experience anxiety as acutely. Now, so that's about anxiety. We're talking about depression. What's the implications for depression? I'm not entirely sure, but there's some possibility that the physical change of a spinal cord injury might actually, again, if depression similarly has some sort of feedback with our body, we might be it might have some impact in our experience of depression, right? So it might relieve anxiety, but there might be some feedback that we use to know that we're feeling good, and that that might put a person more at risk of depression. Okay, again, I'm not sure about that, but that's just one possibility. Now, what's another physical aspect of spinal cord injury? Well, pain. Chronic pain is very common among the SCI population. And with chronic pain is the possibility of catastrophizing that pain. So we know that pain is not just a physical experience. It's also, you know, we think about our pain. We sort of interpret our pain. And catastrophizing pain is an interpretation where the person concludes that my pain is horrific. It's a catastrophe. It's the worst thing in the world. So if a person views their pain in that way, right? So that's not just looking at the pain, but looking at how they view their pain. We know that's associated with depression. And strangely enough, pain catastrophizing wasn't related to depression while they were in the rehabilitation setting, but it was only related after transition to the community. So one thing to consider when a person is being discharged, a person with a spinal cord injury is being discharged, is that you should assess for their pain catastrophizing, because even if they're not depressed currently, if they have a tendency to catastrophize pain, that might be a predictor that they could develop depression after transitioning back to the community. Okay, now, lastly, I want to talk about traumatic brain injury. And traumatic brain injury has a high comorbidity with depression. So 56% of patients who presented to an emergency department due to a TBI later on met a cutoff for depression. And what they found is that TBI severity was a predictor of whether they would have depression or not, as well as previous psychiatric history, alcohol intoxication at the time of the injury, female gender, and non-white ethnicity. The alcohol intoxication is an interesting one, because one possibility is that um, the 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 alcohol present in the system at the time of the TBI might actually uh, impact uh, the physical responses to the TBI, right? So the alcohol might affect the inflammation response, or something about the physical response of to the injury that might put the person more at risk of depression. Or maybe it could be that it's just the psychological factors that could be related to um, intoxication, could be also related to depression. Okay, so all that's interesting to kind of go over it. Of course, I'm leaving out a lot of patient population, so forgive me for that. But I wanted to talk about those few, and I'm going to pause here